Which of the following may precipitate central sleep apnea? Options are opioid toxicity, adenotonsillar hypertrophy, obesity, and dilated nasal septum. Answer of this question is opioid toxicity. Drugs that depress the central respiratory center, such as opioids and benzodiazepine, can cause CSA. Central sleep apnea is a recurrent episodes of apnea during sleep despite a patent airway. The problem is not obstruction, but there is loss of ventilatory drive from the brain that lead to respiratory failure. It means there is no drive from the brain for the respiration. CSA occurs due to temporary loss of ventilatory effort or unstable respiratory control that is commonly associated with Cheyne Stokes respiration that is seen in left ventilatory failure or neurological disorders. Cheyne Stokes respiration (CSR) is characterized by cycling, waxing, and waning of respiration with apneic pauses followed by hyperventilation. This is called CSR-CSA when associated with cardiac failure. Clinical importance of CSA that adversely affect cardiac prognosis and mortality because of sympathetic activation, ventricular ectopy, atrial fibrillation that predict of mortality in systolic heart failure like CSA, right ventricular dysfunction, low diastolic BP. Causes of CSA. First is high altitude, second is neurological disorder, third one is autonomic dysfunction, fourth is narcotic or opioid toxicity, and fifth is after treatment of OSA with CPAP. These are five common causes of CSA. So in CSA, there is central control failure lead to no breathing, which lead to repeated apnea despite there is no upper airway blockage that lead to fluctuating oxygen level or lead to cardiac stress. Management of CSA include treat the underlying cause like heart failure, neurological disease or any drug medications. Second, you can give continuous positive airway, supplement oxygenation and adaptive servoventilation ASP can be given. Now difference between CSA and OSA. Airway patent in CSA while obstructed in the OSA. Central drive failure is there in the CSA while central drive is intact in the OSA. Effort is absent in CSA while effort is present in the OSA. That CSA is common in heart failure and high altitude while OSA is common in obesity and adenotonsillar hypertrophy. Treatment of both is CPAP, weight loss, and in CSA treat the underlying cause and surgery in the OSA. So these are the differences between CSA and OSA. Takeaway messages are CSA is apnea without obstruction, common in heart failure cases, lead to poor cardiac prognosis, and managed by CPAP and underlying condition correction.